psoriasiform reaction pattern, where we have psoriasiform, that is basically what is psoriasiform is epidermal hyperplasia. Epidermal hyperplasia is psoriasiform reaction pattern. Coming on to psoriasiform reaction pattern, so you all know it is nothing but epidermal hyperplasia. Classical prototype is psoriasis, and what you are seeing here is confluent parakeratosis. You saw hypergranulosis in lichenoid. Now here there is no granular layer, that you should remember. There is no granular layer here. Let me just change the pointer. So here, if you see, there is absence of granular layer. There's no granular. There can be some amount of plasma trapping because it's an itchy, scaly lesion, So it can see some plasma trapping, etc. And confluent parakeratosis. Throughout there is parakeratosis. You can also see neutrophils in the stratum corneum. Where you see this regular epidermal hyperplasia, elongated rete, thinned out suprapapillary plates. This is psoriasiform acanthosis. So epidermal hyperplasia, psoriasiform acanthosis. So you classically see psoriasis with all the associated features, confluent parakeratosis, etc., etc. We will derive an algorithm for this also. So now we are seeing similar regular acanthotic psoriasiform acanthosis, but what we are seeing here is parakeratosis that is there, patchy parakeratosis with an orthokeratotic in between, vertical also, transverse also. Okay, when you're seeing vertical also, transverse also, it is called checkerboard pattern, or it is a checkerboard pattern of hyperplasia, parakeratosis, checkerboard pattern of orthoparakeratosis. And where do you see this? It is seen in pityriasis rubra pilaris. Pityriasis rubra pilaris will have a checkerboard with psoriasiform acanthosis and this is psoriasiform acanthosis or close to psoriasiform acanthosis. Little tapering of the retia is seen. Now, what are we seeing here? We are not seeing any parakeratosis. It is regular psoriasiform hyperplasia, but there is no parakeratosis here, but there is compact orthokeratosis. This is a feature of lichen simplex chronicus. This is a feature of lichen simplex chronicus where you're seeing regular psoriasiform acanthosis and a compact orthokeratosis. If you have a closer look, see there's no parakeratosis here, compact orthokeratosis, and a regular psoriasiform acanthosis with minimal inflammation. If you go back, there is not much inflammation. There is just minimal perivascular inflammation. Only vessels are seen, and there is just perivascular. Okay. What is this now? This is, if you see acanthosis, it is not regular, it is irregular. Irregular acanthosis. So little irregularity, but it is psoriasiform, but the acanthotic fronds are little ununiform. There is not much uniformity in the size. So then it is prurigo nodularis. But here orthokeratosis can be seen, but you can also see some amount of patchy parakeratosis in prurigo nodularis. So now coming on to psoriasiform, this is little simpler, and whereas the entities are little minimal, so psoriasiform can reaction pattern, little amount here new terminologies can be seen, regular and irregular. So you have to concentrate whether the psoriasiform reaction pattern or epidermal hyperplasia is regular or irregular. So if it's a regular pattern, then it's with parakeratosis. With parakeratosis or orthokeratosis exaggerated. If it is with parakeratosis or orthokeratosis, first we'll deal with orthokeratosis exaggerated. It is lichen simplex chronicus. With parakeratosis, it is confluent or it is patchy. So you see, once you see parakeratosis, you see whether it is confluent or patchy. Confluent with spongiosis, it is chronic eczema. So you don't tend to see spongiosis and psoriasis or minimal sponges, except for palm, soles, and scalp psoriasis. You don't tend to see spongiosis. Usually you don't tend to see spongiosis and psoriasis. It will be chronic eczema. So without spongiosis, it is most likely psoriasis. So if it is patchy, now patchy parakeratosis, alternate patchy parakeratosis, then it is transverse alternate and it is actinic keratosis. So if it's alternating transversely along the, that is transversely along the keratin layer, then it is actinic keratosis. Vertical and transverse. If it is vertical and transverse, then it is pityriasis. That is checkerboard pattern. Pityriasis rubra pilaris. Now coming on to periosteal patchy parakeratosis without spongiosis. Again, if you observe vertical and transverse, then it is pityriasis rubra pilaris again. It can be periosteal patchy parakeratosis with vertical and transverse parakeratosis. It is pityriasis, but with spongiosis, then it is seborrheic dermatosis. So with spongiosis, it is seborrheic dermatosis. Without spongiosis, you have to again go to the corneal layer and see it is vertical and transverse, then it is pityriasis rubra pilaris. Now, patchy parakeratosis mounts, if you're seeing mounts of patchy parakeratosis, of course, with a prominent Langerhans cell, with spongiosis, etc., it is pityriasis rosea or pityriasis lichenoid pleva, that is et varioliformis acquisita. Pityriasis lichenoides et varioliformis acquisita is the other term, is the other entity that is exaggerated. Actually, if you're seeing mounts of parakeratosis, patchy mounts of parakeratosis is a feature of pityriasis rosea. The pityriasis rosea will be dealt with in spongiotic reaction because spongiosis is more prominent in pityriasis rosea. Now, patchy sandwich pattern of that is, in between you are seeing something entrapped in between the corneal layer and parakeratosis, then it is dermatophytosis, that is fungal infections. Usually these fungi, these spaghetti and meatballs need to be will be entrapped in between the corneal layer. That's why it is called as a sandwich pattern. You can see round or hyphal structures which are PAS positive. Then you confirm with PAS and you get positive for fungal elements. So irregular with orthokeratosis, most commonly single entity is prurigo nodularis. So prurigo nodularis, irregular acanthosis, orthokeratosis, hyperkeratosis, and you see exaggeration, and you see dense collagen, which is vertical oriented in the superficial dermis. That's an associated feature. You call it as prurigo nodularis. Okay. So these are the entities. Again, if you want to just see and what are the entities that you see with spongiosis? There is chronic eczema with confluent parakeratosis. So if you're seeing confluent parakeratosis without spongiosis, it is psoriasis. So you're seeing patchy parakeratosis and alternate transverse, it is actinic keratosis. If you're seeing vertical and transverse periosteal as well, then it is pityriasis rubra pilaris. And with spongiosis and without spongiosis, again, with spongiosis, it is seborrheic derm. Periosteal is what the other name is shoulder parakeratosis. Periosteal parakeratosis, so shoulder parakeratosis. Then we have mounts of parakeratosis with psoriasiform hyperplasia. Then it is pityriasis rosea or pleva. Then you have the sandwich pattern. Then it is dermatophytosis. Then you have irregular acanthosis, orthokeratosis with vertically oriented collagen fibers. It is prurigo nodularis. Okay. So these are the entities that are commonly encountered in a psoriasiform reaction pattern, and usually you can easily diagnose applying these organisms. So remember periosteal without with spongiosis. So once you see periosteal parakeratosis, look for spongiosis in the epidermis. So with spongiosis, most likely seborrheic dermatitis with inflammation in the dermis. Then if it is parakeratosis, there is patchy parakeratosis, periosteal is there, but it is vertical and transverse, then it is pityriasis rubra pilaris. Sandwich pattern, dermatophytosis, mounds of parakeratosis, pityriasis rosea, or pleva. Mounds, that is spongiosis with acanthosis, with patchy parakeratosis, with parakeratotic mounds. Okay. Then orthokeratosis with irregular, that is irregular, there is one entity, that is prurigo nodularis.